The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.
Hello and welcome to the ASCO Guidelines podcast series. My name is Shanna McKernan, and today I'm interviewing Dr. Paul Hesketh from Leahy Hospital and Medical Center, an author on Antiemetics, American Society of Clinical Oncology Clinical Practice Guideline Update. Thank you for being here today, Dr. Hesketh.
Thank you, Shannon. I'm very happy to have the opportunity to participate in today's podcast.
So first, can you give us a general overview of what this guideline covers?
Sure. Many anti-neoplastic agents and certain radiation treatments have the ability to produce significant nausea and vomiting in our patients. Following the introduction of the 5-HT3 receptor antagonist, also known as the serotonin receptor antagonist in the 1990s, as the real first effective and well-tolerated class of antiemetics, ASCO recognized that we needed to develop evidence-based guidelines on effective strategies to both prevent and manage the nausea and vomiting that could be caused by anti-neoplastic agents and radiation regimens used for treatment of cancer. So the first guideline was published in 1999, and comprehensive full updates were published in 2006 and 2011. In 2015, we published a focused update on the first oral combination antiemetic, which incorporated the neurokinin-1 receptor antagonist nitupetant and the 5-HT3 receptor antagonist palonosetron. The current ASCO antiemetic guideline is really the first comprehensive update since the full 2011 guideline. An expert panel was convened by ASCO, and we conducted a systematic review of the medical literature from the period of November 2009 to June of 2016, and 41 publications were included in that systematic review.
And what are the key recommendations of this guideline?
Well, the guideline provides specific recommendations on antiemetic regimens for adults and pediatric patients. And the guideline recommendations are arranged by the inherent emetogenicity of the various cancer treatments. So both anti-neoplastic agents and radiation treatments can be divided into 4 emetic levels: high risk, moderate risk, low risk, and minimal risk. For example, for patients treated with a high-risk anti-neoplastic agent, such as cisplatin, patients should be offered a 4-drug combination of a neurokinin-1 receptor antagonist, a serotonin receptor antagonist, dexamethasone, and olanzapine. Recommendations are also provided for appropriate antiemetic use in a variety of other settings, such as moderate, low, and minimal risk settings, with the use of anti-neoplastic combinations in settings where we use high-dose and multi-day chemotherapy, as is often the case with stem cell transplantation, with breakthrough and anticipatory nausea and vomiting, and with radiation therapy that has high, moderate, low, or minimal emetic risk. I would refer the listener to the full guideline published in the October 1, 2017 issue of the Journal of Clinical Oncology for specific details in each one of these settings.
So as you mentioned, this guideline has been updated a few times since it was published in 1999. So what are the major changes from the last iteration that was published in 2015?
Well, Shannon, the majority recommendations from the last full update in 2011 remain pretty much unaltered, but clearly we made a number of changes in the updated guideline. So those changes include, first of all, recognizing the antiemetic efficacy of olanzapine, an atypical antipsychotic. Olanzapine now has been incorporated into the treatment regimen for adults receiving high-risk antiemetic antineoplastic agents such as cisplatin, or the combination of an anthracycline and cyclophosphamide. Olanzapine is, in these settings, combined with an NK1 receptor antagonist, a 5-HT3 receptor antagonist, and dexamethasone as part of a 4-drug antiemetic combination. Olanzapine is also now a recommended option for patients who, despite optimal antiemetic prophylaxis, still develop so-called breakthrough nausea and vomiting. The second change was the recommendation to limit the use of dexamethasone to the day of chemotherapy alone for adults receiving the combination of an anthracycline and cyclophosphamide, the so-called AC regimen. The prior guideline had recommended administering dexamethasone daily for up to 2 to 3 days after AC chemotherapy, but this updated guideline now is limiting the dexamethasone use to the single day of chemotherapy. A third change was to significantly expand the settings in which we would recommend the use of a neurokinin-1 receptor antagonist. For example, for patients receiving carboplatin and an AUC of greater than or equal to 4, or for high-dose chemotherapy, or for patients, pediatric patients who receive high-risk emetic risk antineoplastic agents, a neurokinin-1 receptor antagonist is now recommended to be used in addition to both a 5-HT3 receptor antagonist and dexamethasone. In addition, the updated guideline also expands upon the prior guidelines for pediatric patients, providing guidance for patients receiving high emetic risk antineoplastic agents who are unable to receive a neurokinin-1 receptor antagonist or dexamethasone. And the guideline also provides new recommendations for pediatric patients receiving moderate, low, and minimal risk antineoplastic agents. In addition, for radiation therapy, the new guideline refines the anatomic regions, the risk levels, and the management recommendations, including the use of rescue therapy alone in the low emetic risk radiation therapy patients. We also have added 2 new antiemetic medications and discussed in the guidelines: rolapitant, a selective neurokinin-1 receptor antagonist, and a subcutaneously administered form of the 5-HT3 receptor antagonist, granisetron. And finally, the guideline panel also addressed the growing interest in the possible use of medical marijuana for cancer treatment-induced nausea and vomiting. The panel concluded that at this point, evidence still remains insufficient for a recommendation regarding the use of medical marijuana in place of the tested and FDA-approved cannabinoids, which include dronabinol and nabilone. Similarly, although there is also expanding interest in the possible use of complementary or alternative therapies for treatment-induced nausea and vomiting, the panel also concluded that evidence remained insufficient for a recommendation for or against the use of such agents as ginger, acupuncture, and acupressure.
And finally, how do these guideline recommendations affect patients?
Well, I think that's very important because if we can find a way to consistently apply these guidelines, I think we clearly have the potential to significantly improve the quality of life of our patients with cancer by minimizing or hopefully completely eliminating the nausea and vomiting that can follow the use of certain antineoplastic agents and radiation treatments. Cancer-induced nausea and vomiting remains one of the greatest fears of newly diagnosed patients with cancer as they anticipate the start of their cancer treatments. If we are able to follow this evidence-based antiemetic guideline, I think we really can reassure these patients that the likelihood of significant nausea and vomiting arising from the treatment is likely to be very low.
Great. Thank you for your insights on this guideline, and thank you for your time today, Dr. Hesketh.
Thank you so much, Shannon. It's been a pleasure to join you today.
And thank you to all of our listeners for tuning in to the ASCO Guidelines podcast series. If you've enjoyed what you've heard today, please rate and review the podcast and refer the show to a colleague.